Greetings, ladies and gentlemen. We now present you the recording of the fifth session of Learning Together group. The talk by Dr. Sarita Kumari on science of sleep was a truly enlightening experience. Dr. Sarita Kumari is based out of Pittsburgh, Pennsylvania. I am sure the audience will feel greatly benefited by her deep knowledge and professional experience in the field.
Okay. So can you see my screen now?
Yeah, now it's visible. Sleep
Yes.
is a beautiful thing, right? Now please
Okay,
continue, ma'am.
perfect. Okay. So a little bit about sleep. I'm not going to give you too much like a medical part, but just in general, how sleep is important for everyone. Now, this is basically to provide you just aware, to make you aware about sleep and some of the sleep disorders which are more common, not intended to diagnose or treat any sleep. Okay, so other question is, please do not ask it because of the recording, don't ask any personal question. And if you do have a personal question, you can directly send me and it will be confidential. And then the second part is, so why do we exactly sleep? So answer is we don't know. Because there is in animal kingdom, we have animals which do not sleep. One of the example is dolphin. When they have newborn, they continuously swim with the newborn and they do not sleep for many weeks without any health issue. There are animals which, based on research, their half brain is sleeping, half is awake, and that actually is seen also in humans when they have a very severe obstructive sleep apnea. Half of the brain is sleeping and half of is not. So we don't know why exactly we sleep. We do have some theory about function of the sleep. And if you see on the right-hand side, where the arrow is, there are multiple theories related to sleep, whether it's restorative or related to growth, like newborn. When they are born, they sleep and they grow. Second is energy conservation, 8 hours sleep, 1/3 of 24 hours we are conserving energy. Adaptive, now these are all English word and you can imagine, you can actually understand, it's not much of a medicine here. Adaptation means basically adapting to environment. Instinctive is more of philosophical than science to me, but basically sleep is an instinct where you develop your instinct. The next one is the memory consolidation. So there are some studies which shows that during your REM sleep, which is one type of sleep, so we have two different type of sleep: non-REM sleep, which is a non-rapid eye movement sleep, and the second type is REM sleep, which is REM rapid eye movement sleep, in which it is thought that the memory is consolidated during REM sleep, especially that procedural memory, like how do you learn or how do you remember how to ride a bike. Again, some people who are on antidepressants or some other medication which affects the REM sleep, they don't have REM sleep, but they don't have any issue with the memory. So this theory is also not completely proven. The next one is your synaptic and neural network integrity and maintenance. Again, when we are sleeping, all the damage or everything is done while we are awake, it gets maintained during sleep time. The thermoregulation, there is a center in the brain which controls our temperature, whether that's related to sleep, because we do have change in temperature during sleep. I'm going to go through that a little bit more. The next function is immune system. If you don't sleep, whether you lose some of your immunity, that was also question raised, not proven. Endocrine system, all hormones, what we have like insulin, cortisol, thyroid, they have a diurnal variation. So in other words, awake level is different and sleep level is completely different. So whether that's a function. The next one, which is the more recent one and a very important one, is whether during sleep we clean our brain. So there is term called lymphatic, and glial tissue is in the brain, and that's how it gets cleared. So its metabolic cleaning does, whether that's the part of the function of the sleep. So in any case, we don't know exactly why we sleep, but we do have some insight about. Now, we don't know why we sleep, but we do know that if you're sleep deprived, which is whether it's an acute basis or chronic basis, you do get excessive daytime sleepiness, which is short form EDS, and there are some effects of sleep deprivation and sleepiness. So there are multiple catastrophes in internationally is recognized because of sleepiness. Chernobyl, and then there was a near nuclear disaster in Pennsylvania and USA. Then another one is gas leak in, not the gas leak, oil leak in Alaska. Challenger is also supposed to be related to sleepiness. And then Bhopal gas count also is supposed to be partly from the sleepiness. So yeah, we know that sleep deprivation and sleepiness can do multiple it can give you some health effect. Now, if you take the research part, these are the effect on chronic basis, and some of them are also an acute sleep deprivation. Impairment of performance, vigilance, attention and concentration, short-term memory, loss of short-term memory, increased reaction time. This is a very important one. Increased reaction time is important in the sense that things which you need to do, suppose right away, it may take some time, and that is one reason for accidents. Some psychiatric illness is also seen after more if you are, it is at, can be precipitated actually if you are sleep deprived or are sleepy. Anxiety and depression. The GI issue is also a common one. The obesity, when in sleep deprived patient, has a little different way to do it. There are two different hormones. We have a leptin and ghrelin. Leptin is a satiety hormone and ghrelin is a hunger hormone. When you're sleep deprived, your hunger hormone goes high, and then people eat a lot because of hunger, and that's how the obese people get obese. If you are obese, again, those are diabetes and cardiovascular disease comes with obesity. And some people see also death. This is actually worked in patients who do shift work. I'm going to talk about a little bit more about this, but there are a couple of very important side effects or health issue related to chronic, especially with the chronic sleep deprivation and sleepiness. So what is normal sleep look like? So we have two different type of sleep. Non-REM sleep, again, it is a rapid eye movement sleep, and this is the major 75% to 80% of the total sleep time we spend in REM sleep, non-REM sleep, and 20 to 25% time we spend in REM sleep. So non-REM is a kind of quiet sleep, and you have dreaming, but it also has divided into three stages. The stage 3 is the one which gives you deep sleep. The stage 2 is the most common type of sleep, but stage 3 is the one which gives you the deep sleep. REM, difference between REM sleep and non-REM sleep is, uh, can I ask you, how do I know that? Hello?
Yeah.
You can hear me, right? Please let me know if you cannot hear me, because I don't
No,
know
no, we
when
can
I.
hear. We can hear you.
Yeah.
Don't worry.
Okay. Perfect.
No, we can
So,
hear you, Sarita ji.
thank you. Thank you. So REM sleep is where you are. It is a very active sleep, considered active sleep, and it is one difference between REM sleep and non-REM sleep, that in REM sleep, because of the active sleep, your muscle tone, you lose your muscle tone, kind of paralysis. So people don't act out. That's kind of nature have prevented us from acting out in our sleep, especially the active REM sleep. The muscle gets very lose their its tone. Now, what are the other types of sleepers? There are one type of people who have very the amount of sleep they sleep is very small, like a 5 hours. They are called short sleepers. Some people require long sleep time, like 9 to 10 hours. These are genetics. You don't create these. These are genetics. Based on your genetics, you can be short sleeper or long sleeper. There are certain other people are called night owls. They work better in during nighttime, or this is also called eveningness. And the other part, is some other people like morning sleep more, a morning waking up in morning and going to bed early. They are called lark. The phase delay and phase advance means phase delay means you go to sleep late. Phase advance means you go to sleep early. That's what it means. I'm going to talk about this a little bit more. If you have these phase delay and phase advance, and that is giving you trouble during daytime, or it is affecting your sleep, your daily life, then this becomes a circadian rhythm sleep disorder. In other words, anything which becomes affects your health in any way, that becomes a disorder or a syndrome. So normally you will have phase delay, but your life is normal. You go to sleep late, but you have not, it is not affecting you. That is, we just call that you have phase delay. Same thing with phase advance. If you go to sleep early, go to bed early and wake up early, that's just a phase advance. But if that is start affecting your life, then that becomes a disorder. So how much normally we need to sleep? The sleep usual duration is between 7 to 9 if you are below 64, and 7 to 8 hours if you are above 65. Oops, sorry. The other important part is what we call sleep inertia. So the sleep inertia is when you wake up in the morning and you have to snooze your alarm multiple times. That's sleep inertia. I'm not going to go into too much detail. The only thing is the sleep inertia is especially common when you are in stage 3, which is the deep sleep. As somewhat in REM sleep also, stage 1 and stage 2 is a good way to wake up rather than waking up in REM sleep and stage 3 sleep, especially stage 3 sleep. There are a couple of multiple innovation like a wearable devices where they can tell you when to wake up and how much you are sleeping. Again, those devices are not approved by FDA here, so I cannot recommend any one of them. There is only one type of device which is we call actigraphy. That means just basically checks your movement and determines you are sleeping or awake. That is approved, and there are multiple devices by what is actigraphy is included. And other than that, I cannot tell you which one you should be using. But that's one way to wake up on time, in your stage 1 or 2, rather than waking up stage 3 or REM sleep. Now this is EEG. I just wanted to give you a little bit about EEG because someone presented a texted effect of on EEG of meditation. And these are normal waves. The beta, alpha, theta, delta, slow wave, and gamma wave. These are normal waves. These are normal brain waves. And these are found in different stages of sleep. When you have low frequency like delta and theta, those are in a deeper sleep. REM sleep is very active sleep. You will see gamma burst, which is high frequency wave. This is when you are thinking or concentrating. And that's why people think that REM sleep is an active sleep. Because during REM sleep, feels like the EEG looks like a awake person. There are other way to recognize that this is REM sleep, but that's what happens during the REM sleep. It looks like that kind of you are awake. So meditation effect, we can talk about later sometime what happens during medication, how the EEG changes. There are drugs which can affect medication, which can affect your EEG. Most commonly, we see these two, SSRI, which are antidepressant, and benzodiazepine. They both decrease your deep sleep and REM sleep. And one of important part is benzodiazepine like lorazepam, diazepam, all those medication basically take away your deep sleep and REM sleep, and you will stay mostly on stage two. SSRIs also can do the same thing. One problem with SSRI that sometimes they get REM rebound. In other words, they are deprived of REM sleep for a while, and then suddenly they one day they will have a very many more episodes of REM sleep. And some people who have nightmares, that can be precipitated because nightmares happens during REM sleep. So that's one of the side effects of SSRIs. There are other disease and disorders out of scope of this talk, but they can affect your EEG also. So the next topic. So one of the very important question is how do you regularize your sleep? So we have two different processes. One is we call process S, which is the environmental or external factor. So process S involves that when you are getting light and sound and all the daytime actions of day, you are awake. And when everything is quiet and dark, you go to sleep. That's basically your environment and called process S. During daytime, when you are awake, two things happen. You create a sleep debt. In other words, you are awake and you are creating a sleep debt, and also there is hormone called a chemical called adenosine, which is built in your brain while you are awake. It is important to understand this part. If you take a nap, you are decreasing your sleep debt. So that's not a good idea to nap if you have insomnia or any kind of sleep issue. You should not be decreasing your debt, rather you should keeping your debt high so you can go to bed at time. Adenosine also important because it is a sleep, it is built up during when you are awake, but this is a sleep promoting chemical. In other words, it is built up in your brain so you can go to sleep during night time. It is, it is, it is adenosine, caffeine is the adenosine receptor blocker. So once you drink coffee, basically you are ruining your accumulation of adenosine. And coffee, the half-life is 4 to 6 hours. So you need two half-life to to metabolize caffeine. So you shouldn't be drinking coffee after or any caffeinated product after lunchtime. So those are process S or homeostatic drive or environmental drive, whatever you want to call. It is important. Now, what are the stimulation here? What regulation here? One we call photic regulation, another is non-photic regulation. Why I included this? Because retina, we all know what retina is, I'm assuming. Retina has a pigment called melanopsin, and that is a very potent light, the photopigment which takes the light, and blue light is very well absorbed by this photopigment. And that is the reason why you shouldn't be exposing yourself to your electronics at bedtime, because now you are giving this light when you're supposed to be sleeping. And that's also blue light from electronics, which is very potent way to stimulate your retina and melanopsin. So that's why it's like a 4 to 5 times more than the regular white or yellow light. Blue light exposure to body is good in the morning, especially blue light is very well reported in between 7 to 11 a.m. from sunlight. And that improves your mood and decreases your insulin resistance. So there are very many benefits. But at bedtime, blue light is not good way to do something. Non-photic regulation, I'm going to talk about this a little bit more. It's what called thermoregulation or regulation of core body temperature, which is CBT. So core body temperature is, I will talk about a little bit. First, let's go on the left side. The next process is what we call process C or circadian. So we have a body clock or what we call master biological clock. Hypothalamus is a part in the brain which is in kind of mid part of the brain, and there is a nucleus called SCN or suprachiasmatic nucleus. That is our biological clock, and that clock provides a rhythm. That means we go to sleep and we wake up on time. So that's a 24-hour clock, and because of this nucleus, this is the nucleus. It gives us a rhythm. And how do we know that this is a rhythm? This creates the awake and sleep rhythm, because they did a study and they put the subject in complete dark room and without any kind of external interference. But those subjects were still able to go to sleep and wake up at their time. So yes, this works separately than process S. So process S, the environmental factor; process C, the internal factor. So external and internal factor, when they both together, then your sleep is very regular and it is synchronized. So what is the time when you can fall asleep very easily? Usual latency, sleep latency, that means time to fall asleep, is between 8 to 20. In elderly, it can go up to 30 minutes. And best time to fall asleep is, or your circadian rhythm makes you fall asleep easily, is between 2 a.m. to 6 a.m. and mainly between 3 to 5 a.m. And that's why sometimes even a person who has very poor sleep, they can fall asleep easily at this time. The second wave is between 2 to 5 p.m. or around between 3 to 4 p.m. 4 p.m. is where you need a coffee break because you are sleepy. So those are the two sleepiness part, which is run by this circadian, by the SCN or our master clock. Now I put here peripheral clock. Each cell has actually a clock. I don't want to talk about more detail about, but there is all cell in the body. Most of the cell in the body, they have their own rhythm. They have the peripheral clock, and that works with this master clock. So every part of our body has a rhythm, and these need to work together. Now, what time is your longest sleep latency? Means what is the time when you have most difficult to go to sleep? And that is about 1 to 2 hours before your habitual bedtime. In other words, if you do not create enough adenosine in your body and you have taken big nap, you are not going to fall asleep at bedtime, your habitual bedtime. So if you want to go to sleep and go to sleep fast, those are the process you have to follow. Don't take nap and do not drink coffee after lunchtime. Now, on the right-hand side, I have mentioned phase advance and phase delay. So if you want to advance your phase, in other words, you want to sleep earlier than what you are doing that right now. So assume that you went to sleep at 12 midnight and you wake up at 8 a.m. About 6 a.m., your body temperature will be lowest. That's what's called CBT minimum, core body temperature minimum. If you want to advance your sleep phase earlier, you want to go to sleep earlier, you have to expose your to certain amount of light after this CBT minimum. If you do opposite, you are going to advance your sleep phase further. And the second medication, which is also can advance your sleep phase, is melatonin taken either late afternoon or evening. And the third is if you do exercise in evening, that can make your phase advance so you can sleep earlier. Now, I will not suggest just to do this on your own because all three have a protocol and you need to get in touch with your sleep doctor and work with what works for you and best. One thing is important: after you take melatonin, do not expose to yourself to a very bright light because melatonin works only when the light is dim. So that's the important part. The next is if you want to delay your phase. In other words, if you want to go sleep a little late rather than 8 p.m., then you have to expose to yourself light before the CBT minimum or before the core body temperature drops to minimum. You have to take melatonin in morning and you have to do exercise in morning or night. Again, I will not suggest to do this all on your own. You need to get in touch with the sleep doctor because there are protocols how to do, but this is how it is done. Melatonin is a naturally produced by pineal gland. Some people call it third eye. humans do not have any photoreceptors whatsoever in pineal gland. So no pineal gland does not see anything. But there are animals who have photoreceptor in pineal gland. We can talk about why pineal gland is called third eye some other time, but that's the hormone is released. The melatonin comes from many other parts of the body because many adults have pineal gland calcified and they do not have problem with melatonin. So it's not just the melatonin is not just secreted by pineal gland. The next is circadian misalignment. So now we talk about process S and process C that need to be aligned. In other words, when environment is sun is bright and out and noise and all those regular activity daytime, you cannot sleep. You should be staying awake. And when it's time to go to bed to sleep in night, that's what you are going to go to sleep. And that's what called circadian alignment. When you misalignment that, then you have circadian rhythm misalignment. Most of the time, this is seen in patients who does shift work. So what do you mean by shift work? So like if you are someone is doing morning shift, then they are doing afternoon shift, the evening shift or night shift. So different shift in other words. So on those patients, we see this circadian misalignment. If you are doing shift work, you should be doing rotating shift. In other words, go for morning, then afternoon, and then evening, and then night shift, and then go back to morning. That's what we call rotating shift. Social circumstances is the most common nowadays of a circadian misalignment. We do many things in night. We expose ourselves to electronics. So that is misaligning. We are misaligning our circadian rhythm to environmental. In other words, external, internal factors are misaligned because of social circumstances. Blindness is another one where they do not see, they do not have light, and it can be misaligned. Circadian rhythm disorders are called delayed phase sleep disorder, advanced phase sleep disorder. They have non-24, which is also seen in blind people, and the irregular. In other words, they have no sleep pattern whatsoever. They can go to sleep, or they can stay awake differently. There are certain long-term risks of these misalignment of circadian rhythm. Number one, obesity. Again, people who have this misalignment, they can be sleep deprived, and the same leptin and ghrelin can be more of ghrelin and hunger hormone, and that's how you can be obese. Metabolic syndrome, which is very important one, long-term exposure of metabolic syndrome, which includes insulin resistance, diabetes, high blood pressure, GI issue, and many other cardiovascular risks is associated with this circadian misalignment. Cancer is actually reported in shift work disorder. So there are multiple studies done in shift work disorder in which it is reported that incidence of cancer was higher in patients in shift work. So whether that is also a risk factor. Now, what is insomnia? So there are too many things written here. Please do not try to read. I'm going to talk about each one of them. Number one, when you have difficulty initiating sleep or maintaining sleep, or you are waking too early, or you are unable to sleep on time. Any of these can be called insomnia. But there are things which need to be associated with this. You should have some symptom related to insomnia, like you have excessive daytime sleepiness, fatigue, mood irritability. Many patients will complain that they have concentration problem or memory issue. Multiple accidents have happened because of the insomnia. Motivation, this is a very common one. If you ever have multiple days of very poor night of sleep, you will feel that you don't want to do anything. So reduced motivation is actually a very important one. Also, people frequently are very dissatisfied with their sleep. It has to be at least 3 times a week. And it has to be despite bedroom conducive to sleep. In other words, you cannot say, okay, someone is disturbing my sleep, so I have insomnia. No, you have plenty of opportunity and place and time and comfort to go to sleep, and despite that, you are not able to sleep. That's then only it is called insomnia. Also, it cannot be. It is not better explained by anything else. In other words, if you have pain, you will be awake. That's not insomnia. That's simply pain keeping you awake. It has to, so to call insomnia, it has to meet all these features. There is, especially, I just want to talk about primary insomnia because this is without any other issue. This sometimes starts during high school in very young age, and this stays for lifelong. These are the patients who are very hyper arousal. They are like always aroused. They don't feel sleepy despite very little sleep, and this is very hard to treat. I just wanted to give you about a little bit. Young people can face this insomnia too. There are certain factors which can predispose and precipitate or keep you having insomnia. I can send you the list if you want to, but I didn't put because the slide was too busy. When do you call it short term? When it's less than 1 month? When it called chronic? Nowadays they said more than a month. I do not agree with that because I had insomnia for a month and did not have any problem. So, so again, this is not a, but the recent definition is that if you are not sleeping well for 1 month, more than a month, you have insomnia. So how do you treat insomnia? First things first, you have to have very good sleep hygiene. You should have a regular bedtime and rise time. And irrespective, this is very important. Irrespective of what time you go to bed, always wake up at the same time. So rise time should be always the same. Do not take nap. Avoid caffeine after lunchtime. Alcohol is disturbs your second part of the sleep. So there is two half of sleep. First half, alcohol may make you fall asleep easily, but the second part is very disturbed. So alcohol is not a good sleeping agent. Some people do that, but it's not necessarily a sleeping agent. If you do any aerobic exercise, very heavy aerobic exercise at bedtime, that can make your sleep difficult. So should not be doing any kind of very heavy exercise just before 2 to 4 hours before bedtime. Gentle exercise is very good. You can do the brisk walking and all that, but not to go running on treadmill at 5 or 6 miles an hour. Again, keep the bedroom quiet and dark. This is very important. Dark is means pitch dark. It has been shown multiple ways that darkness is very important, and cool environment. Also, keep it cool. People look at the clock all the time if they are unable to sleep, and that is not a good idea to keep a clock if you keep looking at. Remove the clock. Evening eating, heavy meal at bedtime, also not a good idea. So how do you treat? So there is term what we call CBT or cognitive behavioral therapy for insomnia. And I'm not going to go into each of them. Two of them I have placed here. One is your sleep restriction. So if you are sleeping for 6 hours, don't stay in bed for 10 hours. Stay in 6 hours. In other words, if you are not sleepy, do not go to bed. When you are sleepy, go to bed. In other words, restrict your time in your bed for sleep only. Do not read paper or watch TV or do all kinds of electronic stuff in bed. So there is a good protocol. If you would like to, I can send you, but I will say you should always, for CBT or cognitive behavior therapy, you should always get in touch with a psychologist. Nowadays, they are doing video chat and all that. So it is a very good idea to get in touch with psychologists. The second one is the stimulus control. So stimulus control means you shouldn't be doing anything which stimulates your brain in night. So let's see, if you go to bed in 20 minutes and if you are unable to sleep, get out of bed. Go in a room, walk, gentle music, don't expose yourself to light. Just have a gentle music or something nice reading. And when you feel sleepy, come back to bed. If you have to do this multiple times, do that. Keep the rise time same. That's the important one. The third part is your cognitive part. Now, I'm not going to go through all the detail. Stimulus control also has a protocol I can send you if you would like to. The cognitive part is very important. Most people have trouble just thinking about and getting frustrated that I have poor nighttime sleep. I don't sleep well. This is disturbing and all that, rather than an actual effect of not sleeping. So if you did not sleep, don't get frustrated. We don't even know why we sleep. So it's not a big deal. Do not think about too much about sleep. In other words, that's the cognitive part. So we have two different type of treatment for sleep for insomnia. One is your cognitive behavior therapy, and second thing is medication. Most people require both. The CBT is the first line of the treatment. If you see the guideline by American Academy of Sleep Medicine, all the evidence suggests that long-term effect of medication is weak. Now, weak doesn't mean the potency of the medication. Rather, it is the research part which is the weak. So they divide into strong recommendation versus weak recommendation. So the weak means whatever evidence or research we have, we do not have enough evidence that this is going to be treat your insomnia forever or without any problem. So the evidence is weak in terms of medication. So yes, there are certain risks associated with uh, long-term chronic use of sleep medication. And I'm going to next part. So this is just an example of article. If you click on this on in Google, just put exactly this article, you can see this article. Now, before we go to article, I just want to talk about few things. So let's assume that the 100 people we chose, number one, how the medication is developed. So someone does some kind of uh, research in lab and they come up with a plan or chemical and they try first on animals and then get in touch with pharmaceutical company, then phase 1 trial, phase 2 trial, phase 3 trial, approval by FDA, and then goes to marketing. FDA has a website, have a division where the post-marketing adverse event on chronic on medication which is already in market you can place. But think about what happens if I give a sleep aid to 100 patients, 50 of them have side effects. Those side effects are all listed, and 50% goes to doctor and talk about this. What happened after that? Nothing. Literally nothing happened. So there is no good way to know. And the reason why I'm saying this because someone asked about to talk about the chronic use of sleep aid. So there is no good way to know what exactly happens to those people. So someone come up with a great idea that why not we interview those people who are on these medications. One of the publication is this. It was published in 2000. The interview was taken. Basically, you can go and look into detail how detail oriented. Okay. So in other words, if you go to this article, they have a very detailed questionnaire and all of them, like multiple people have a high incidence of residual effect of those chronic users, residual effect of medication. They have problem at sleep related problem at work, home, and including social relationship. They have also mentioned about cognition on patients who are chronically using sleep aids. I tell you the truth, unless until we have each and every medication listed, I cannot tell you which one is worse than one other. But one thing is important. If you are on benzodiazepine or antidepressant, after reading this, don't stop right away. It needs to be very tapered off. Okay, so do not do this, and this is specifically because I thought whether I should be presenting this or not. And I just want to warn you that sudden withdrawal of these medications can give you side effects, and especially in benzodiazepine, you can give seizure. If you are taking 7 days a week for many days, many months or weeks or years, you cannot suddenly stop those medications. So yeah, it need to be tapered. Same thing with antidepressant. It should not be stopped suddenly. Next is a common one. I just came to know. I can give you the data in U.S. 22 states in United States are reporting obesity up to 33%. So obstructive sleep apnea is becoming a big phenomena. It is a worldwide problem. I'm not going to go through everything. I just want to point out about anatomical risk factors and some symptoms. So what are the anatomical risk factors? If you're obese, that's a risk factor. Male gender is a risk factor for developing obstructive sleep apnea. Any kind of facial abnormality, like recessed chin or any other craniofacial, or if you have nasal polyp, which is kind of lobulated thing inside your nose, and people who are allergic to many things, they develop. They also have what we call rhinitis. That's a nasal kind of inflammation. Then the next part is septal deviation. So you have nose, the two nostril, and the septum is middle and it's in the center. If you see some people have that is deviated on one side, so the other side gets very constricted, and then actually puts you at risk for sleep apnea. At least it's mild one. If you have big neck in male, it's more than 17 inch, 17 or more, or in female, it's more than 16 inch. You check at the Adam's apple. If that is the size, it puts you at risk for sleep apnea. The palate has two parts of the palate. One is the hard palate, which is the front where you have the teeth attached, and the low and the soft palate, which is on the back of the throat. If your if your hard palate is very high and arched, you can look into your mouth. If that is very high and arched, that puts you at risk for obstructive sleep apnea. If your soft palate is very low lying, that also puts you at obstructive sleep apnea at risk. If you have family history of snoring or sleep apnea, you can have sleep apnea too. If you have very large tongue, or if you open your mouth and you don't see anything inside your mouth because everything is blocked by tongue and other soft tissue, you don't see your back of your throat, that is crowded oral cavity is a risk factor for obstructive sleep apnea. If you have these risk factors, and if you develop, even if you don't have sleep apnea, if you gain weight, you will develop sleep apnea. Now, what are the other things which can mimic sleep apnea? So there are many heart disease and lung disease that can mimic. They may have similar symptoms as sleep apnea. So not everything which disturbs your sleep in night uh, uh, is actually sleep apnea. Some people get laryngospasm, which is from it's a voice box spasm in your voice box. It is from reflux, acid reflux. Sometimes you get that, and those people can feel like choking and gasping for air, similar to what we see in sleep apnea patients. Sometimes seizure. I have seen a case where seizure patient was seizing and in night only they have nocturnal seizure, and that can be sleep. It can disturb your sleep, and people can think that it is a sleep apnea. These are I just put here, but this is more for the medicine. There are different types of sleep apnea. Snoring doesn't mean that you have sleep apnea. So there is a rhythmic way patients who have sleep apnea, they sound. They will snore, and then stop. So that's the important part is they do not continuously snore. They will drop their snoring, and they will be apneic during that time. Now, sleep apnea, you snore, you have apnea. Apnea means basically you quit breathing during sleep. So what happens when you lose your muscle, in night, some people lose their muscle tone more, and they have tendency to collapse their windpipe, and there is no airflow, and that's what called apnea. During that time, your oxygen level drops, your carbon dioxide level goes up, and you struggle to breathe, and you wake up. This happened multiple times during night time. And because of that, and sometimes you don't even know, you will just wake up in night and you will not know why did you wake up. Sometimes you just go from deep sleep to lighter sleep. So sometimes you can hear your own snoring and you wake up. So there are multiple symptoms of sleep apnea. If this is if those choking and gasping and quick breathing, all associated with drop in oxygen saturation, then it's sleep apnea. If it is without oxygen saturation drop, then it's called upper airway resistance syndrome. So snoring and upper airway resistance syndrome doesn't have much of a health issue, it's just annoyance to your partner. Now, how do you assess? You can actually assess yourself whether you have sleep apnea or not. I like this. Anesthesia doctor uses all the time when someone comes and they don't have diagnosis of sleep apnea. But if the anesthesia doctor thinks that this person may have sleep apnea, this is what they use. So stop bang. This is the short form. So S is for snoring. T is for tired. Person feels tired all the time during daytime. O is observed, means someone tells you that, yeah, I snore, and you quit snoring in between. That's observed for snoring and apnea. P is pressure, that's high blood pressure. If you have high blood pressure, B is your BMI, if that is more than 35. Age is more than 50, and neck is more than 16. G is your gender. Male gender is more risk for high obstructive sleep apnea. If you have 5 to 8, you are at high risk for sleep apnea. In other words, you have actually, when you are given anesthesia, and if you are not on breathing machine, you can become apneic. So that's the reason why anesthesia doctors measures this. The next slide. Someone asked me to talk about a little bit of obstructive sleep apnea. I'm not going to talk too much. I just want to point out that there are 3 different types of treatment available for sleep apnea. I don't know what is available in India. I know that India CPAP is available there. So CPAP is basically a continuous positive air pressure. So it is a machine connected to a tubing, and the tubing is connected to a mask. Once a mask fits on your face, nose or mouth, depending upon what fits you and what you like. And once the machine is turned on, it generates the air pressure, and that pressure keeps the windpipe open. That's what the purpose of the CPAP machine is. The second type of treatment is what we call oral appliance, that is done by dentists. They basically fit you with the appliance, and you have to sleep, and you have to go with the sleep study to see if the appliance is working for you or not. You should be continuously going to see a routine follow-up with dentist, and off and on you need to go for sleep study whether your dental device is still working. If you gain weight, it may not work. Also, it is not going to work for severe sleep apnea. In US also, there is what we call Inspire. That is a surgical implant for moderate to severe sleep apnea. There is some contraindication. In other words, not everyone, if your BMI is 40, you are not eligible for this implant. But that's another one. Nasal spray. If you have rhinitis means just a kind of nasal congestion all the time. You clearing your throat because something drips on your back of your throat, and that's from rhinitis. There are some steroid spray you can use. You can use the saline spray, which is basically a salt spray, and gel. You can use that. Also, if you have mild sleep apnea or snore, you can sleep on side, especially sleep on the left side. So positional, some people put a tennis ball behind their back so they don't sleep on back. If you have sleep apnea, it is worse during REM sleep because you lose your tone and your muscle become more flabby. And also your obstruction is worse in your back when you sleep on back. So yeah, it's a good idea if you have mild sleep apnea, don't want to be treated, sleep on the side. There are certain risks associated with untreated sleep apnea, obstructive sleep apnea, especially if it is moderate to severe. Very many people we have seen atrial fibrillation, which is the abnormal rhythm of a heart, and stroke. That's a big one. We have so many patients who come with a stroke and atrial fibrillation have untreated sleep apnea on long-term basis. Heart attack, worsening of heart failure, and of course, high blood pressure they can develop if you have untreated moderate to severe sleep apnea, especially on long-term basis. So if you have sleep apnea, if you feel that those are the risks you have, your stop bang score is high, better you go and see a sleep doctor. see a sleep doctor. Once you have treated, you need follow-up. It cannot be without a follow-up. You cannot have just one sleep machine given to you and you forget about it. Because you need to know, we need to know whether your sleep machine is still works for you. And if it is working, ideally, you should be using as long as you are sleeping. Because think in this way, that you are sleeping and your oxygen level is dropping and you are depriving oxygen of your entire body, including your brain. And some of the issue with the sleep apnea is that they may have some memory issue. So that's why it's important. Cleaning, weight control, alcohol, nicotine, or any drug which can worsen your sleep apnea, like a benzodiazepines, those are bad for your sleep apnea. That can make it worse. So again, it is important that you follow up. There are few things you can do, whether you are whether you have a excessive sleepiness or not, to find out. This is what we call Epworth sleep scoring. There are 8 circumstances which you can check, and never means you are not sleeping or dozing off while you are sitting and reading. But every time you are watching TV and you go to fall asleep, there is a high chance of dozing off. So you give the score of 3. So you get these scoring, and if you have sleepiness, if you are sleepy, if its score is more than 10. And associated disease, again, sleep apnea, narcolepsy, we can talk about that. It's too long, we don't have that much of time, but there are multiple diseases which are associated with excessive daytime sleepiness. And then we can go through this too at some time if we have time. Few lines about parasomnia. So what is parasomnia? Basically, anything abnormal you do during sleep is a parasomnia. So there are 2 different stages. We have non-REM and REM sleep. During non-REM, you can sleep talk, you sleepwalk, you can have heard about that. So people are leaving their house and doing all kinds of things while they are sleeping. So those are called parasomnia. There is another thing, what we call night terror. Basically, waking up in night, still sleeping and terrified. That happen in non-REM sleep. Eating disorder. People have gone to fridge and eat and empty the fridge, and they don't even know. The only way they knew that something is wrong because they are gaining weight. REM sleep has 2 disorder, what we call REM behavior disorder and nightmare. This is in PTSD patient, post-traumatic stress disorder, very common in military personnel. They get PTSD and they get nightmare. They get very vivid dream. One of the difference between non-REM and REM is the dreams in REM sleep are very vivid and you will remember. So nightmare is basically they see whatever they have seen during their active duty time, and that gives them nightmare. And REM behavior sleep disorder is basically you lose you have very full tone. You do not lose your tone during REM sleep, and you act out on your dream. Parkinson's disease is one of them, which is a kind of degenerative dementia in which many patients get these RBDs, and this can precede 3 to 4 years before they get actual dementia. So a couple of patients are diagnosed 4 years after this having Parkinson's disease or dementia. Restless leg is another one. I know we don't have much of time, and only thing I will say that this is a uncomfortable, unpleasant feeling in your leg, and you constantly want to move, and those feelings can go away when you move your leg. This is a very common disease, but very poorly recognized. People do not think that moving your leg is abnormal, but actually it does. You have to, it is an abnormal thing to do, constantly move. Now, I'm not talking about habit. For some people have habit, but it's not about habit. This is just the uncomfortable and unpleasant sensation, which is worse during inactivity or in night. When it is only in night, it is called periodic leg movement disorder. Why it is important? Because it can be associated with untreated sleep apnea. And the only complaint will be that my bed is messy, very messy, and everything is on floor. And that tells you that you move a lot during sleep. And then there is a website for this. This is a website which deals with RLS or restless leg syndrome.org. You can find everything. But if you move your leg, if you have intense desire to keep moving your leg, please go to this side, because it can be treated. Some people have iron deficiency anemia that can worsen their RLS or can precipitate. Some people who are on SSRIs or antipsychotic, many of the psychiatric medication can either worsen your restless leg or precipitate your restless leg. Alcohol, caffeine, antihistamine like Benadryl, Phenargan, or can precipitate or worsen your restless legs. The next is teeth grinding. So I have seen many people teeth, and I can recognize that this person grinds the teeth. But itself, bruxism, especially when it is vague, other than damaging your teeth and damaging your temporomandibular joint, which is a joint which connects both jaws, there's not much bad effect. But it gives you pain in your temporal mandibular joint, can give you a headache, and of course you lose your teeth. Basically, the height of the teeth is literally gone. It can be worsened by alcohol use, loud snoring, too much of caffeine, anxiety, stress level. All these can affect your bruxism or teeth grinding. Why it is important when it is sleep related. When you have sleep related, any of these disorders can do this. You can have parasomnia and people grind their teeth. You can have untreated sleep apnea, you can grind your teeth. You are on multiple antipsychotics or antidepressant, you can grind your teeth. Some of the drug abuse or recreational drugs can make you grind your teeth. There are multiple other neurological psychic history, family history. Those all can make you grind teeth. So treatment is basically to use a jaw. It's kind of denture. It's basically mouth guard, and you have to go to a dentist to see and get fitted. This is a very important disorder, attention deficit and hyperactivity, or ADHD. Nowadays, there are so many people are adult life, they are diagnosed with ADHD. And why this I did that, because I put this here, because ADHD frequently associated with delayed phase. So people with the ADHD frequently feels that nighttime is the best time. They are very creative and they do all kinds of things. But sometimes that delayed phase becomes disorder. And then in other words, this delayed phase start affecting their daily life during daytime. Then it becomes a syndrome. And it has been shown that when you treat this delayed phase, their attention deficit, their ADHD gets better too. So that's why I put this here, because one treatment of one disorder can help you in both. So these are the helpful hint. American Academy of Sleep Medication. You can look into all the guidelines, how they come up with the guideline. They always take the randomized control trials. They exclude all the business related or marketing ones. They also exclude observational or any like a population based study. So it is a very extensive way to come up with a guideline. And again, these are guidelines. There is no hard and fast rule. You can do whatever works for you. But this is if you want to go through whole thing, that how this is, whatever I have talked to, how the recommendation comes, this is the place to go. This is more of a medical, but if you go to National Sleep Foundation, it has very layman term used. And it has many diseases, what I talked about. And it has details. Restless leg, again, this has its own website. And this is .org. These are all .org, so those are not commercial sites. The reason why I put FDA for two reasons. Number one, dietary supplement. There are so many supplements nowadays, both for sleep and everything else. if you want to know which drug has a post-marketing adverse event, you can go to FDA website for that, and also all the dietary supplements. One of the important is right now many people, I don't know how much in India, but here omega-3, turmeric, and aspirin, they use all three together, and some of them are actually on blood thinner too. That is a very bad idea. We have seen patients of excessive bleeding when they are on omega-3, turmeric, and aspirin all together. You can bleed to death by those taking all together. So if you are on any blood thinner, please do not take omega-3, turmeric, or aspirin. I mean, aspirin certain time you have to take, but omega-3 and turmeric, please do not take that. Those are put you at risk for any kind of bleeding, especially when you are going for procedure or any kind of surgery. Usually doctors do not ask about your dietary supplements, and so that those need to be discontinued. Now, NIH.org, we all know this site. There are two sites NIH has. One is for complementary integrative health, in which homeopathy is included, and the next one is for heart, lung, blood, and that includes sleep. And that is very nice site if you want to go there, in case if you have any interest in sleep. And this is my last one. So we think that Kumbhakaran has likely had Klein-Levin syndrome, which is a genetic disorder, and in which person just sleeps and sleeps and sleeps. You have to wake up. It's very difficult for them to wake. And this is the last one. I love this Shakespeare, that act. And again, have a good night, sleep well, and thank you. And I'll take few questions because I don't think we have time. Okay.
So, Madam is opening it for people. If you have questions, please raise your hand. I will be able to see who has raised your hand.
I cannot do that.
Any questions based on what ma'am discussed just now? Do you have some time, ma'am? Maybe.
Yeah, I have time.
Yeah, okay. It normally takes time for people to react what they have heard and ask questions. It happened last time also.
Yeah.
So my request to you is, in your personal experience, you have shared it a lot with us. Would you kindly summarize what are the things that you would like people to do or not to do if they want their sleep pattern to be real?
Okay. Hold on a second. I'm just trying to.
In the meantime, I got some personal messages or even otherwise that people were either able to see the video in which ma'am from the ma'am or only they are able to see the PPT. Most of them have said that they have not been able to see the PPT. Now, Madam has been just a second. Madam has been sharing her PPTs with me last week. We have been discussing corrections, etc. If she permits, then I shall post on our WhatsApp chat the PPT, the final one that she has sent to me. So, Madam, do I have your permission?
Yes, I do.
Okay. So, what I shall do is I shall post that whoever sends me the mail ID, maybe there are people like Varun or Rakesh Vajpayee, I shall forward ma'am's PPT mail to everybody who wants it. Now, ma'am, go ahead.
Yeah, so I don't see any question, any raised hand.
So far.
Ma'am, I have a question.
Yes,
go ahead.
Hello?
Please unmute
Yeah,
yourself.
this is Anurag. So, ma'am, this is Anurag. I have two questions. My question is that, nowadays I see there are a lot of different practice doctors actually treat sleep apnea. Which is the best doctor to go for a sleep apnea if you have one and you want to get diagnosed?
So again, I cannot recommend which is the best doctor, but someone who's board certified. They all are. You don't get like a board certification. It is a separate training. So go to anyone who's board certified. Number one. go to any doctor who is pulmonary and sleep, because if you have lung issue, you can actually take care of both. Like some people have asthma and sleep apnea. You can go to see a lung doctor, or some people just do the sleep on neurology. So you have to choose in your area. You are in US, right?
That's right, ma'am.
Okay, yes. So you have to choose which insurance or who is your provider. Choose that way. Again, tell you the truth, I am in Pennsylvania, and if I remember, you are in New Jersey. So I cannot recommend any particular doctor. But
No,
but
no,
that's what.
the reason I ask, ma'am, is for I see that there is a like your general physician, dentist, eye, ear, nose, pulmonary. Everyone treats sleep apnea, so it becomes a question that who's the right doctor, if
Yes.
anyone has who want to
No,
go to
that's
it.
why, yes. Someone who is certified in sleep medicine, irrespective of what is their underlying, go to the person. The ENT doctor do not treat sleep apnea, but they do implant, the surgical implant we talked about, the Inspire. They implant. It is done by ENT. It is a surgical implant. But if you have a sleep specialist, someone who is certified in sleep board, DM, did the DM in sleep, go to them, irrespective of what else they have done, whether they are neurologist or. I will prefer. I'm a pulmonologist. I think we are best. So I will say go to a pulmonologist who is certified in board certified in sleep medicine.
Excellent. Now, would you
Yes.
just summarize, ma'am? Would you just summarize in your personal experience and the people whom you know, what would you say do's and don'ts are in short?
Do's or don'ts of sleep or sleep apnea.
No, sleep, general sleep.
So the number one, again, we have talked about that there is a process C and process S. That means the environmental external factor and internal factor has to be aligned. In other words, when it's time to sleep, go to sleep. Do not stay awake and expose yourself to blue light. That is basically misaligning your circadian rhythm. And also, if you have any kind of sleep trouble, do not drink coffee after lunchtime. And also, do not drink alcohol or nicotine or do very heavy exercise at bedtime. Those are the things. So, sleep hygiene, I have placed sleep hygiene, which is very important. All the do's and don'ts in that sleep hygiene is listed. I can send you more detail if you want to. But aligning your external factor with internal factor is the most important one.
Excellent. Actually, since you have done lots of work in collecting those websites, I'm very sure those who are into it, they would find lots of benefits while going to the
Yes,
website.
yes.
Now, Adesh Krishna has a question. What is the best diagnostic process for sleep study? It's
So,
on.
so okay, that's a little bit extra, but I can tell you there are home study, and there is in lab detailed study, what we call polysomnography. So the polysomnography, where they check your EEG, your brain waves also, they check your flow through your nose, they check your muscle activity, EKG, and oxygen saturation. So it's a very detail oriented and it is the final study for sleep apnea diagnosis. Final in the sense there is nothing after that. So, but there is a screening test. You can, if you don't have any medical problem or do not have any heart or lung issue or do not use oxygen, people do the home study first because it's a comfortable environment. And it is completely okay if you are young and have no heart or lung issue. You can start with your home study.
Adesh, Adesh, please unmute yourself and see if you have anything else to add to that or ask. Adesh Krishna. Adesh.
No, that yeah, and the other thing I wanted to ask was that polysomnography, which is done, how often should one go for the review and do it and take that again?
Okay. So the polysomnography done and you are diagnosed with obstructive sleep apnea, you were given CPAP. If that is the case, then you go a follow up with for your CPAP. Not necessarily you have to go for polysomnography unless something changed. Like some people lost a lot of weight and they want to know whether they still have sleep apnea or not, and sometimes they do go to polysomnography. Not necessarily it is indicated, but some people do. Polysomnography is only diagnostic, and if you are using your CPAP and CPAP is showing that your sleep apnea is very well corrected and you are using adequately, you don't need to go for repeat polysomnography ever.
Excellent. Dr. Jha, Dr. Rajchandra Jha,
Yeah,
please.
I just wanted to ask one question. Are you aware of any genuine study about certain asana that we are asked, yogasana, we are asked to practice before going to bed, or some breathing exercises or pranayams? Because these days we are flooded with such information on the social media, on electronic and print media. Just wanted to verify if in the States there has been any controlled study on this aspect.
Yeah, so I will say no. There is no controlled study. It is very hard to do on human a randomized and controlled trial. But I can tell you, my personal experience is the meditation in night like Savasana actually works. It is my personal experience. As a sleep doctor, I know that works. So I think now light exercise includes yoga, light yoga, and you can do before bedtime, 1 or 2 hours before bedtime, and that is actually conducive to sleep. So the exercise in terms of exercise, but I cannot tell you whether any particular asana is better than other asana. It's basically exercise. And of course, the purpose of meditation, one thing which I did not tell you, that some people have insomnia because they think too much on bed. Once they go to sleep, you have light is off, it's clear, it's a dark, and nobody's talking, then everything comes in your mind. And you are unable to sleep. I think that's how meditation works, because you remove your focus from every thinking, and now you are just focusing on one thing and you quieten your mind. So that's one way, that may be one reason why meditation or savasana or whatever you want to do in night works. The second option is that keep a chair next to your bed and think before you go to bed in chair, and exhaust yourself as much as thinking you want to do that. And once you feel like you are sleepy, then go to bed. And some of my patients, this was a great idea and worked for them. Because thinking in bed is a real problem nowadays. Because you have stressful life whole day, especially the young generation. They have multiple things to go, and not only that, what they have to do next day, they start thinking about that in night too. So yeah, thinking is kind of very disturbing to your sleep.
Actually,
Thank you. Thank you very much.
Dr. Jha and I perhaps are on the same, on the same page. Dr. Jha, I had only one question to ask Madam, and I did some research also, some preliminary research. According to the data available, the alpha waves between 8 to 12 hertz, they are the beginning of meditation. When you start meditating, and if you go into slightly deeper meditation, you go into that 8 to 12 hertz alpha. And during the deepest stage of sleep, it's delta, which is 0 to 4. Alpha is during meditation. And during deep sleep, you have anti-aging hormones, melatonin, etc. Actually, I did not find a single source which said that there has been a real medical study done.
Yeah.
Having said that, they insist that there have been some very visible effect of going into meditation, but not essentially before the sleep. They ask not to go into that deep meditation before the sleep, probably 2 hours before that, and exactly what Dr. Sarita said, just before the sleep, go and sit on a chair and exhaust yourself by trying to concentrate on one point. So she has already answered my question, so I'm not going to repeat that. But yes, meditation is not supported by, and she's again right, there are so many parameters, so many variables, very difficult to control them. But as you also rightly said, Dr. Jha, that it is not very far from real effect that meditation does help, and exactly because it's a sleep meditation takes you between 0 to 4 hours of delta against that sleep. So, anybody else has a question?
Dilip Trivedi wants. Dilip Trivedi ji wants to ask.
Dr. Jha, are
Ma'am,
you
hello.
Dilip, hold on. Dr. Jha, are you through?
Question you have to.
Yeah, yeah.
Okay, Dilip Saab, please go ahead. Unmute yourself and go ahead. Dilip Trivedi, please unmute and go ahead.
I am not question.
Dilip, please unmute yourself.
Okay. Am I audible now?
Yes.
Yes, I can hear you now.
Yeah, doctor, just one question. Would you recommend reading before sleeping? Because I have been doing that, and that actually puts me to sleep.
Yes.
Is that a good thing to do?
Yes, just don't expose yourself to light. You can have light on book, not your on eyes, and make sure it's not a light which has more of blue light. And also read about something gentle, not like some kind of
Not murder
novel.
mysteries or anything.
Yeah, mystery, exactly. Murder mystery, not good idea to watch kind of murder mysteries.
Okay.
Yeah, so
Thank you.
gentle
Okay.
book reading, yeah, book reading is completely fine.
Thank you. Thank you, ma'am.
Mandeep raised a hand. No. Okay, so we shall summarize it. I will, Dilip Trivedi, Varun Kumar.
Ma'am, I have one question.
Yeah, go ahead.
Ma'am, when we sleep, I mean, our mind stops working, or is it awake?
So this is a very good question. So in there we have two different type of sleep. One is called non-REM sleep, which is quiet sleep. So your mind is not working that much. But REM sleep, which is a rapid eye movement sleep, if you see the EEG pattern, this has it's like awake, that you are awake and you have multiple gamma bursts. So gamma burst is when you are concentrating, when your brain is very hyperactive. Those gives you gamma waves. That frequency is 30 to 120 hertz. So during that time when you have, so that's why it called REM sleep is very active. Your breathing can become erratic. You can have abnormal heart rhythm, and you can have a very vivid dreams, and you remember those dreams. So the nature protects us by losing the muscle tone. So you are completely kind of paralyzed. So yes, your body is not active, but your brain is active during REM sleep.
Varun, we have in science lots of discoveries which happened in the dream. Nicolay found the structure of benzene in the dream. R.L. Stevenson wrote the entire novel in his dream. So of course we do things.
We are very active.
Yeah.
Actually, ma'am, I was so much worried about my dream. Like when I was in class 10, I used to see trailers of movies on YouTube or anywhere else. And after 2 3 weeks, the whole movie I used to see in the dream only. And later, when I watched the movie, like after 2 3 months or 6 months, there was there were 70% of similarities in my dream, in my movie that I saw in my dream, and the real movie that I watched later. So I also was
Deja vu.
Yeah. So this is called extrasensory perception, and this is out of medical field. I mean, there is some extra
Acha.
sensory perception is that you will have vision of future, basically. So it's one of the extrasensory perception is that people can see things, what is going to happen, of future. And so, no, we don't know whether this is a real extra, in terms of medical. Personally, I believe that is a possibility. But in medicine, there is nothing like, nothing is proven that there is human beings have this kind of capability. Nothing in medicine.
Acha.
Varun,
Okay. And ma'am,
yeah, go ahead.
just one.
Yes,
If a person sleeps soundly and he has no dream, and a person who sleeps too much and he has many dreams, so which person is having a good sleep? The person who is sleeping peacefully without any dreams, or the person who is sleeping deeply and having dreams?
So, so if you have if irrespective of dream, If you are sleeping deeply, in other words, if you have appropriate REM sleep and stage 3 sleep, it is better with or without dream. Dream and sleep, we don't know why we dream, why we sleep. There is not much of a correlation. People used to think that dream and during REM sleep you have consolidation of your all the memories and everything. So we don't know exactly how to correlate. Now there are people who have nightmares. That means those are frightening dreams, and those are seen in some of the diseases like a PTSD, post-traumatic stress disorder. This is also called parasomnia. If you remember night terror, that's the that's the dream or frightening dream, and those are disease. Okay, and there are treatment. Those can be very disturbing. Those will disturb your sleep. Now think about that. You are sleeping deeply and you are dreaming about beach. That's not a bad thing to do. That's not a bad thing. So when dream becomes disturbing so much so that is affecting your sleep, then only it is bad. And two types of dream are nightmare, which is in REM sleep, and night terror, which is on non-REM sleep. Night terror people will just say that I woke up and I had this frightening dream. Sometimes they will not even wake up. They are just frightened. They look very frightened. And when they are awake, they will not remember what kind of dream. In REM sleep, when they have nightmare, they will have very vivid memory of their nightmares when they wake up.
Wonderful.
Did I answer your question?
Varun? Yeah, okay.
Yes, ma'am, you have answered, and I will later ask on WhatsApp. We should
Okay.
not take it too much long because of me.
Okay.
No. So we always have the chat open.
Yes,
I,
yes.
I would conclude with that line from Paul Valéry, the French poet. The poem never ends; it only gets suspended. So this time I shall say any intellectual activity, like from Dr. Shirish last time or ma'am right now, we are just suspending it for some time, and we shall continue for the week talking about it, and maybe God willing, 2 months later she will be there again. Number one, and to my mind, the most important. This session was basically timed to address the younger ones, and my definition of younger ones was 25 years to 40 years, right? Many of them do feel that do not need such sessions. I respect what they think. Uh, 2 or 3 are here. They asked me personally to have a particular session on finance, why finance should be there taught in class 12 to motivate their children. 2 of them are here, so I will not name them. I want to speak few lines, maybe a couple of minutes on this. Number one, if you have somebody who can have a session on finance which will help the young ones, please let me know. Please invite them. The forum belongs to all. I have already asked Mani and Shivindu from USA. But if you have somebody who can take the session, please let me know. I will go and request the way I have been requesting others. Point number one. And point number two, in psychology, attention, what we say attention, and what helps us in excelling our professional life is earning more money. The attention is an intentional, unapologetic, and discriminatory exercise. It's unapologetic and discriminatory. We only want to concentrate and attend our focus on what is going to help us in life. And in that process, we miss out a lot what is going around us, what is going inside us, what is going in front of us. These sessions are primarily will be designed basically to let you know what you could be missing and what could still be useful under inverted commas. There is a book, I forgot the name of the author, I shall post it. He says, art of seeing what we miss. Art of seeing is to be learned, and there are 11 steps. I shall forward the book. The one step he says that seeing the people who have lived it, hearing the people by looking at their face who have lived it. So what is the information here which you cannot get on the internet? Actually, much more than that. What is happening here is people like Shirish sir, madam right now, they are not only giving the words which can be found everywhere. Behind the words, there is a soul. behind the words, there is a consciousness which they have developed over 40 years, 50 years. That is what you will get if you are alert while listening to them. So I request my younger ones who will see the video recorded, please go through it. It is definitely going to make you see what you have otherwise missed. Thank you very much.